radiologist. جزيل الشكر للأستاذ الدكتور محمد أبو الهدى والدكتورة منى شلبي على الدعوة. سعيدة بتواجدي مع كوكبة من الستاف، على رأسهم الدكتورة رندا طبعا والدكتورة سهير والدكتور محمد صبري والدكتورة منى شلبي. دلوقتي أدعو الدكتورة هبة النجار، lecturer of Radiology at Shams University، هتكلمنا عن ال PET-CT sometimes tricky.
Good morning, dear professors and colleagues. My talk today is about PET-CT, which is sometimes tricky. The objective of this lecture is to review some cases to highlight and reveal the tricky side and pitfalls of PET-CT. Of course, not all of them, but part of them. We'll start with the different systems of the body, and first we go with the CNS. And here, the first case, this is a lymphoma patient who was in complete remission for more than 18 months and was referred for his routine follow-up PET-CT at our unit. As you can see from the MIP image, the first one, the black and white one, you can see there it looks unremarkable apart from the hyperactive bone marrow. But is this image or this study is sufficient to judge the brain parenchymal uptake? As we all know that the brain metabolism depends mainly on the glucose. So you have, it's normal to see bilateral, symmetrical, increased FDJ avidity of the brain parenchyma. But don't get fooled by this uptake. You have to reduce the FDJ uptake of the brain and look carefully at its parenchyma. When we reduced the FDJ uptake, you can see that there appeared 3 focal abnormal areas of increased FDJ uptake between the brain parenchyma that was suppressed. And when we reviewed the fused images, you can see that there are 3 space-occupying lesions, left high parietal parafalcine and bilateral cerebellar FDJ avid lesions. And this case was reported as relapsing CNS lymphoma. We proceed to case number 2, and this patient, non-small cell lung cancer patient who was referred for follow-up. As you can see from the MIP image, we can see only the right lung pathology and the left chest wall FDJ avid lesion. But when we lowered again and reduced the metabolic activity of the brain, appeared a very small focus of increased uptake in the right parietal region. As we look to the conventional CT image, and luckily it was a conscious one, we can see that there is an ill-defined high enhancing lesion here in the right parietal region. When you look at the fused images, you can see there is increased metabolic activity, focal increased metabolic activity here, and this is a space-occupying lesion, metastatic deposit from the lung cancer. By the way, the prior study that we were comparing this study to, they missed this space-occupying lesion, but luckily the patient was improving overall, so this lesion has reduced in size too. As we proceed, here to show you some of the normal physiological uptake that you can see in the PET-CT images. Bilateral symmetrical uptake in image A in the adenoids, while in the image B, this is the heart palate uptake. Also, these are examples of normal physiological uptake in the parotid gland and the vocal cords. Now, let's look at this case. This patient shows focal FDJ avidity at the back of the tongue associated with a pathologically enlarged FDJ avid lymph node. This is a case of cancer tongue, and the patient received chemotherapy, referred for follow-up. As you can see here, there is marked metabolic and morphological regression in the primary tumor as well as the lymph node. We'll proceed to the second case, and you can see there is a right parotid swelling with an FDJ avidity. It's not always remember that FDJ avid lesion is not always neoplastic or malignant, because this lesion was proved histopathologically to be a pleomorphic adenoma. We'll proceed to the third case, and this is a lymphoma patient who was referred for PET-CT assessment. As we can see, there is normal bilateral physiological uptake in the salivary in the salivary glands. But when we looked at the contrast-enhanced CT images alone, we can see there is a pathologically enlarged enhancing lymph node within the right parotid gland, and this is a case of parotid lymphoma. The lymph node was hiding behind the normal physiological activity of the parotid gland. We proceed here, and this is a patient of lung cancer who was referred for PET-CT assessment. The first thing you look at is that there increased FDJ uptake at the right vocal cord, but when you look carefully at the CT, you will find that there is a slight medial deviation of the left vocal cord and widening of the laryngeal ventricle. And here the pathology is not on the right vocal cord, the pathology is on the left side. There is left vocal cord paralysis secondary to invasion of the recurrent laryngeal nerve by the chest tumor. Here we proceed. This is a straightforward one. The FDJ avid lesion is seen on the right vocal cord and reaching the anterior commissure, which is FDJ avid, and this is the pathology. This is a case of cancer larynx. As we proceed here, these are two different patients with breast cancer and referred for PET-CT assessment. What we can see in the fused image, there is focal increased FDJ uptake at the lung parenchyma, suspicious for pulmonary nodules. But when we looked at the CT images, in the first one, you can't see anything corresponding in the CT images, and this is not a true pulmonary nodule, this is an FDJ embolus. But in the second case, there was a true pulmonary nodule seen at the lateral segment of the middle lobe. We proceed to the second case, and this is also a known case of breast cancer who was referred for PET-CT assessment. Now you can see there is a mild low-grade metabolic activity overlying the surgical bed with dense calcifications. Now the question is this recurrence or it's just overcorrection due to dense calcification? If we look at the MAC images, you will find corresponding increase in the FDJ avidity. Now we go to the non-attenuation correction images, and when we look at it, there is no pathological uptake, and this is only overcorrection on top of dense calcification seen at the lesion. We proceed to do different patients of lymphoma and both referred for PET-CT assessment. In the fused images, we can see areas of abnormal FDJ uptake at the mediastinum, suspicious for mediastinal lymph nodes. But look carefully at the conventional CT images. In the first case, there is no corresponding lymph node present. It is only fat density. So this is normal uptake in the epicardial fat, and it's not a pathological lymph node. In the second case, we can see there is a rounded small mediastinal lymph node. So this is an FDJ avid lymph node. This is a true lymph node. Here, image to show you the normal thymic gland. It's triangular, and sometimes it can show avid uptake, as we can see in this image, and not considered to be pathological. Let's take a look at this patient who was lymphoma and referred for a PET-CT assessment. Here in the first row images, you can see the thymic gland is too small in size and shows fat density and with no or minimal or insignificant FDJ uptake. The patient received chemotherapy and was referred for another PET-CT assessment. You can see there is increase in the size and the metabolic activity of the thymic gland, yet it retains its triangular homogeneous shape, and this is rebound thymic hyperplasia, which is very common with chemotherapy patients. But here to show you the difference between the homogeneous one we saw in the previous case, and this is a case of cancer thymus. You can see here the thymus has lost its triangular shape, showing an irregular speculated soft tissue mass with central breakdown, and this is a case of thymic carcinoma. As we proceed, this is a young female patient who was lymphoma and referred for PET-CT after complete remission for 1 year. Here we can see at the pelvis there is not pathological, there is an area of increased FDG uptake. Now, the first thing that comes to your mind is this an pelvic lymph node, this is recurrence or what? But if you look carefully at the CT images, you will find that this is linear, normal physiological uptake in the ovary, and you can see also there is a follicular cyst next to rising from the right ovary, so this is normal physiological uptake and not a pathological pelvic lymph node. There's an interesting finding here is that we also found bicorn with uterus, so this is normal ovarian activity with bicorn with uterus. This is a patient with colorectal carcinoma who underwent surgical resection and referred for PET-CT assessment. In the conventional CT, we can see the surgical clips. In the fused images, there is focal increased FDG avidity, suspicious for recurrence or residual tumor. Again, we look at the MAC image, there is increased in the uptake, but when we look at the non-attenuation correction, we can't see any the definite or significant FDG uptake, so there is over the uptake due to overcorrection on top of the surgical clips. In this case, this was a patient with a transitional cell carcinoma in a urinary bladder diverticulum who underwent surgical resection and referred for PET-CT assessment. In the early scan, you can see 3 focal areas of uptake suspicious for recurrence or residual tumor. So the patient was, delayed images were obtained, and you can see here there is a change in the site and the size of the focal FDG avidity, and this is normal FDG avidity hold up of the tracer within the urinary bladder and the urinary bladder divertically with no recurrence or residual tumor, and this is the delayed CT image. You can see both the urinary bladder and the divertically show homogeneous wall with no definite masses. In this case, this is a patient with a cancer sigmoid who underwent surgical resection and we also referred for PET-CT assessment. You can see here a focal increased FDG avidity inferior to the urinary bladder, and it looks from the first look, you can consider it a urinary bladder diverticulum, but the patient has slightly elevated tumor markers, so delayed images were obtained, and you can see the uptake is persistent and focal in this particular site. So his a biopsy was taken and proved to be recurrence and not a urinary bladder diverticulum. In this case, the patient had a uterine tumor and underwent total abdominal hysterectomy and bilateral salpingio-oophorectomy and was referred to us for PET-CT assessment. Here you can see the operative bed is clear with no FDG avid lesions. But as we go down, you can see there is a non-FDG avid suspicious looking left external iliac lymph node. So this lymph node, we'll consider it suspicious. Why? Because we don't know the metabolic activity or the metabolic behavior of the primary tumor. Maybe the primary tumor was non-FDG avid, and as we all know that the metastatic deposits follow the metabolic signature of the primary tumor. And this is the first PET-CT study, and we don't know about anything about the tumor behavior. So we consider this lymph node to be suspicious for close follow-up after treatment. My take-home message is PET-CT is an excellent tool in hidden pathologies, yet it's tricky sometimes and maybe a double-edged weapon. Don't get biased by the FDG uptake because it may be misleading. The FDG avid lesion is not always the pathology you are searching for and not necessarily an evil one. Never ignore the conventional CT images for morphological details and always trust what you see with your eyes. And keep the metabolic signature concept always in your mind when you interpret any PET-CT case. Finally, PET-CT is not the magical solution in each case, in all cases. There must be a proper clinical data, proper communication between the radiologist and clinician in order to reach a final proper diagnosis. Thank you.
شكرا جزيلا دكتورة هبة، الحقيقة very interesting and very important talk. ولو احنا لسه بنعمل المونثلي كونفرنس بتاع الوحدة بتاعتنا يعني محتاجين نقوله دايما يعني ونكرره ونضيف عليه حالات تانية كمان.
ممكن
ودلوقتي
اسال بس سؤال صغير دكتوره هبه؟
اتفضل.
اولا شكرا لاسم الاشعه على دعوته ليا، شكرا دكتور محمد الهدى، شكرا دكتور ايه حسين، شكرا للشير بيرسون الافاضل. معلش انا ككلينيشن بقى محتاج اقول بس سؤال صغير حضرتك. احنا كتير جدا بنشوف ميني بيشنتس عندهم انسان اكتيفيتي عاليه جدا عشان بياخدوا جلوكوفاج او سيتوفاج او بياخدوا علاج للسكر، وده بيهدن ساعات الناس اللي عندهم كانسر كورن او كوريكتال كانسروما. ف what's your opinion about this issue because the patient should be controlled diabetically قبل البات سي تي، وفي نفس الوقت هو بياخد علاج بيخلي الجلوكوز كونتنت في الانتستين اعلى، ودي نقطه طلعت فيها هايلايتس في الاي سي ار عندكم، ان البيشنت اللي هو بياخد سيدوفاج او جلوكوفاج او تورليستي او الحاجات اللي بتقلل او بتقلل السكر في الدم بس بتزود الانسان اكتيفيتي should be omitted قبل الاشعه. احنا بنشوف ده كتير في الناس اللي هم كانسر كولون عندهم ريسكشن في الانستموتيك لاين وبياخد علاج للسكر، وبتلاقي الامعاء التستن كلها اوباسيفايد في البات سي تي. حضرتك عندك تصور لحل المشكله دي؟
لا كده شغال. صباح الخير، ازي حضرتك؟ طبعا هو اول حاجه زي ما حضرتك قلت، احنا اول حاجه بنأكد عليها دايما مع العيان هو الجود بريباريشن علشان نقلل الفاليسيس يعني ويطلع الفحص مظبوط باقصى يعني اقصى حاجه نقدر عليها. تاني حاجه احنا عندنا حاجات كتير. اول حاجه انا مش بس بعتمد على الفيوزد ايمج لوحدها او الماك لوحدها، لا انا عندي كمان سي تي. لازم ابص كويس الاول على السي تي ايمجز لانها تديني مورفولوجيكال ديتيلز قويه جدا، اقوى كمان من الماك لوحده والفيوزد ايمج لوحدها. فبشوف كمان الابتيك. طيب عاده الابتيك اللي هو بيبقى انفلاماتوري او في العيانين الدايابيتك بيبقى ديفيوز وهوموجينس، وبلاقي الابتيك مينلي في الوال بتاع الانتستين، ولما ابص على الوال نفسها في السي تي هلاقيها فيري ثين ومفيش فيها اي ماسز او ثيكنينج او حاجه سسبيشس. طيب كل دوت جميل. طب ما عرفتش بعد كل دوت، لازم احنا عندنا في الوحده مثلا العيان ما بيتحركش من الوحده غير لما نبص على الفحص. لازم حد من المدرسين المساعدين او المدرسين يبص على الفحص ويتاكد ان هو تمام وان هو مش محتاج حاجه كومبلمنتري ايمجز ثانيه للعيان. الحل التاني معايا ان انا باخد للعيان حاجه اسمها ديليد ايمجز، بقعد العيان ساعه وبعد كده بدخله يتصور تاني على المكان السسبيشس اللي انا شاكه فيه. ليه اللي هيحصل؟ اللي هيحصل انه زي مثلا الحاله اللي انا وريتها اللي هو العيان بتاع اليورينري بلادر دايفرتيكولر تيومر، الاف دي جي افيديتي النورمال اللي هي ماشيه في الباث واي النورمال بتاعها هتتحرك، مش هتفضل ثابته في المكان. لكن المكان اللي هو سسبيشس اللي فيه سوفت تيشو نيوبلاستيك ومالجننت هو عمال ياخد الاف دي جي، عمال ياخد الماده وعمال ياخد الجلوكوز، فهو هلاقي المكان بيرزيستنت، نفس المكان دوت فيه increased focal uptake موجود زي ما هو بالظبط. وبس كمان في بعض الحالات ومعظمهم بلاقي ان الاف دي جي الاس يو في ماكس نفسها كمان عليت، يعني الاقيها في الايرلي سكان مثلا 6 أو 7، لما ابص على الفيلم الديليد الاقيها بقت 12 بقت 10. فده بيقول لي انه لا المكان دوت سسبيشس، انا عندي هنا ليجن فعلا حقيقي، حتى لو انا بقى فشلت اني اشوفه في السي تي ومش واضح حلو، لا انا عندي هنا ليجن حقيقيه، والليجن دي كمان غالبا 90% نيوبلاستيك لان الاس يو في بتاعتها عماله تعلى وهي عماله تاخد التريسر بشراهه يعني.
بالمناسبه بحاله البلادر دي انا معجب بيها جدا لان انتوا مصورين عينه هو بلادر فول، مع ان ده مش البروتوكول بتاعنا ان احنا عين تو فويد قبل ما يعمل بات سي تي عشان البلادر ما تبقاش مليانه والداري مثلا لو في كانسر بروست او حاجه. فكنا هيك عملتي يعني بلادر مليانه وتصورتي يبقى انت عندك فيجن انت بتتابعي حاجه في البلادر.
لا هي الحقيقه هي بس هي يعني احنا عندنا حالات كده، بس هي دي يعني دي من الليترشر مش بتاعتنا في الوحده.
تمام.
لكن احنا عندنا البروتوكول بتاعنا انه يورينري بلادر كانسر او يعني البروستات ليه بروتوكول مختلف شويه، لكن يورينري بلادر كانسر والستومك والحاجات اللي هي فيها ليومن واحنا محتاجين نفرد الوال كويس، لازم بننفورم العيان اولا بيتصور مرتين ولازم يبقى فول بلادر، ولو اتصور والبلادر مش مليانه او الستومك مش ديستندد كويس بندخله يتصور تاني. يعني
حاجه بس اخيره بقى عشان دي نقطه مهمه جدا عندنا في الشغل، الا وهو اللوبلر كارسينوما في البيت سي تي. اللوبلر كارسينوما في البيت سي تي. البيت سي تي اي ثينك ان هو في بيت فولز عنده، يعني بكملت بقى النقط كلها. اللوبلر كارسينوما دايما بتبقى فيه لو اف دي جي ابتيك، واحنا دايما بيبقى تريكي جدا البيت سي تي في الكومنت بتاعه انه ما عندناش اكتيفيتي عاليه، فاحنا دايما بنريلي للمورفولوجيكال نوت ميتابوليكالي في اللوبلر سب تايب اوف بريست كانسر.
ما هي
they are always low FDG uptake.
ما هو هي نفس نقطة الحالة بقى الأخيرة دي بتاعتنا اللي هي الميتابوليك سيجنتشر. ما أنا مش شرط الحاجة اللي FDG avid هي دي الباثولوجي، أنا لازم أدور على الليجنز، يعني زي الليمف نود اللي في الحالة الأخيرة دي. الليمف نود دي ممكن تبقى ميست فيري ايزي لو ببص بس على الفيوزد ايمجز، لكن احنا شكلها باي سي تي فيها suspicious criteria، وبيكوز مش شرط لازم اشوف الميتاستاتيك ديبوزيت هتفولو الميتابوليك سيجنتشر. فلو انا عارفه ان التيومر اللي انا بتعامل معاه في الاساس ده نون اف دي جي افيد، يبقى انا الفيوزد ايمج هيضللني جدا لو اعتمدت عليه لوحده. لازم هبص بقى على السي تي علشان اقدر اطلع الباثولوجي فعلا فين موجود، واطلع الحاجات اللي فيها الفايندنجز وافيد بقى العيان. يعني لازم اديله في الاخر ريبورت مش بس ان ما فيش اف دي جي افيد ليجنز، لا لازم اطلع له ريبورت بكل الليجنز اللي موجوده سواء اف دي جي افيد او مش اف دي جي افيد.
شكرا.
شكرا جزيلا دكتوره هبه.